Can I stand here?
Yeah.
Okay. Assalamu alaikum. How are you guys? I think it's been a while. The last time I think someone else gave the talk and it went very well. So alhamdulillah, I'm back. So you have to deal with me one more time. Sorry. So today we're talking about a very interesting topic to me, personality disorders. It's actually one of my favorite topics in psychiatry by far. And the reason is it's not a very concrete subject, and I'm not a very concrete person, so it's nice. There's a lot of abstract ideas in it and a lot of interesting psychological concepts in it. We're not going to go too deep into it, but we'll be able to go deep enough where we can have some nice discussions, inshallah. And you know how I present. You guys can ask questions throughout the presentation. That's pretty relaxed, so we'll get started. I'd like to start out with my just disclosures, and I'm a psychiatrist at Pine Rest Christian Mental Health Services. I'm a clinical professor of psychiatry at Michigan State University Department of Psychiatry. I'm an education student at Johns Hopkins University. I'm part of the Muslim Mental Health Conference. I am on the research committee. We go through the abstracts that people submit and things like that. And I'm on the board for Movement for Outreach, Volunteerism, Education. Our objectives today is that by the end of this presentation, you guys should be able to define what personality disorder means, identify the common personality disorders and their general manifestations, and discuss the significance of these disorders and their impacts on family and public health. And that's going to be more of the discussion portion. So before we get into the clinical topic, I wanted to kind of talk a little bit about Narcissus. So Narcissus is actually a perennial flower. It flowers every year. It's a bulb, right? And it's called Narcissus. It originates in the Mediterranean region in Europe. Actually, that's a picture of a narcissus that I took a picture of in Virginia when we used to live in Virginia. It's a beautiful flower. And some say it was named due to its poisonous bulb because it causes stupor and death. Others say due to its intoxicating fragrance. And the name is basically derived from the Greek word narke, meaning numbness or stupor. So that numbing feeling, so we have narcotics, you have narcissus, you have narcissism. It's kind of like, they all have the same root meaning of causing stupor and numbness, and we'll talk more about that as it relates to personality disorder. And like many plants, it's hermaphroditic. So it falls in love with itself, breeds with itself, and creates other flowers from itself. And then this is a picture, a very famous picture of Narcissus from the Greek mythology. So Narcissus was in Greek mythology, he was someone who, a lot of people loved this guy. He would walk around and people would adore him. And he would turn them away and make them feel bad. And one time, a female, her name was Echo, she was following him, and he knew someone was following him, so he said, "Who's there?" And then she replied, "Who's there?" So she echoed him. And then she made herself appear to him, and she expressed her love for him. And he turned her away, shunned her, and threw her, basically told her to get out of here. So she went into the woods, got lost in the woods, and lived the rest of her life there, and all that's left of her is an echo, right? So that's where the term echo comes from, kind of. And as a punishment, the goddess Aphrodite got put in Narcissus' way a pond of water. And he went and he looked into the pond and he fell in love with his image. And he fell in love so much with his image that he ended up committing suicide because the image couldn't reciprocate its love back. How does that relate to anything? Well, we'll see. But I just wanted to start with that kind of introduction. So he fell in love with his image, the image didn't reciprocate, and then he killed himself. So a personality disorder is a way of thinking, feeling, and behaving that deviates from the expectations of culture, causes distress or problems functioning, and lasts over a long period of time. Before I get started in the actual personality disorders, I just want to tell you guys that a lot of the symptoms and things that we talk about, a lot of us will have some of these things. What personality disorders are is this cluster of defense mechanisms. We all have defense mechanisms. We defend ourselves against other people. We defend ourselves against ourselves sometimes. We have these defense mechanisms like when we do denial, or we use humor or sarcasm. These are all defense mechanisms, correct? And we all have them. So what a personality disorder is a cluster of immature or low-level defense mechanisms. We are going to have some of these. When it becomes a cluster, that's when it's a problem. So please don't sit here and try to diagnose yourselves or anything like that. Enjoy the presentation, learn from it. Usually I give these presentations so that we could learn how to help others. I guess this one is more learn about these defense mechanisms, learn about these personality disorders, see what parts of these maybe exist in you that you would like to change or something, but don't be highly critical of yourself. Don't be, oh my God, I have that or I have this. It's okay. If you think you have something, you probably don't. But yeah, but just as a word of caution that a lot of us will have some of these things, so don't take it too much to heart. Is that clear? All right. So how do we so in psychiatry, we classify things. We love to classify and put things into boxes because it makes clinical life a lot easier and more useful for the clinician and the patient. But we classify personality disorders as cluster A, cluster B, and cluster C. And don't worry about memorizing things. Just get the overall vibe. Unless you really want to take notes, that's fine too. Cluster A, these are personality disorders that are more odd. They're odd people, eccentric, they're bizarre. They have these weird ways of thinking, they're quirky. So that's cluster A personality disorders. Cluster B, these are the dramatic and the erratic. They're very impulsive people, very impulsive personality structures. And cluster C are the anxious or fearful personality structures, all right? Some people will say, okay, well, so what's the difference between like an anxiety disorder and a cluster C personality disorder? They're different in the sense that these are basically cognitive ways that people think and view the world, while anxiety and depression and those are more like biochemical things that happen. They're not necessarily part of the personality. So you could think of a personality as a Christmas tree of the person, and the other disorders as little ornaments that kind of decorate the Christmas tree. Does that make sense? Yeah? All right. I like Christmas. So cluster A. Cluster A personality disorders are these: paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. You can see that schizo is common in two of those. It's different than schizophrenia, but we'll talk more about that. So paranoid personality disorder, right out of the DSM. DSM is a book that we use in clinical psychiatry, and I think a lot of psychologists also use it, and social workers are familiar with it. Basically to diagnose patients and clientele. And this is right out of there. So paranoid personality disorder is a pervasive distrust and suspiciousness of others such that their motives are interpreted as malevolent beginning by early adulthood and present in a variety of contexts as indicated by 4 of the following. They suspect without sufficient basis that others are exploiting, harming, or deceiving him or her. They're preoccupied with unjustified doubts about the loyalty or trustworthiness of friends or others. They're reluctant to confide in others because of unwarranted fear that the information will be used maliciously against him or her. They read hidden or demeaning or threatening meanings into benign remarks or events. So someone will say something, they'll read into it, like, he really meant this. Persistently bears grudges, is unforgiving of insults, injuries, or slights, perceives attacks on his or her character or reputation that are not apparent to others, and is quick to react angrily or to counterattack, and has recurrent suspicions without justification regarding fidelity of spouse or sexual partner. As you can see, it's a way of thinking. They're constantly looking for double meaning, double things, something else going on. You said this, he probably meant this. No, I meant what I said, but no, he meant something else. It's different than schizophrenia. So schizophrenia or delusional disorder, those are different. Those are not personality disorders. This is different in that the person is not separated from reality. They're still in reality. This is just the way they live their life. They're very paranoid people, but they're not delusional to the sense where they lose touch with reality. It's not like they think the CIA has tapped a microchip in their brain and is after them, like a schizophrenic would or someone who has delusional disorder would, right? That's different. These are more likely the kind that they're just mistrustful. So in my clinical practice, I'll see someone with paranoid personality disorder. They won't confide in me anything because they think I'm going to take that information and put it somewhere else, or I'm going to call their school and get them kicked out of school. I had a patient one time who wouldn't tell me anything because he wanted to go to college, and he thought that all the information he would tell me, I was going to tell it to somebody else. He wasn't delusional. He was just paranoid. He kept thinking that I was going to somehow this information, I'm going to just go and talk about it. Or he thinks that you know, after our appointment, I would go and just make fun of them to somebody, even though that just wasn't true. So that's kind of a paranoid type of cognitive thinking, cognitive structure. Paranoid personality disorder affects about 2 to 4% of the population. It's not commonly seen in the clinical setting, so a lot of times they don't come to seek help because they distrust everybody, right? So if they distrust the clinician, why would they come to see the clinician, right? Why would they come see a social worker or a therapist or a psychiatrist if they're already distrustful of people? It shares features with several other personality disorders. It's not psychotic, but rather a paranoid cognitive style, as I said. So it's a way of thinking that's altered or not functioning properly. No medications are currently approved to treat this, and you'll see with personality disorders, medications are not really approved. This is a personality structure. It responds more to psychotherapy than to medications. Medications would be used to alleviate any symptoms of the personality disorders that cause like violence or agitation or things like that, but you don't use the medications to cure a personality disorder or help personality disorder in the same way you would use it for depression, for example. You're using the medications to target specific symptoms. Most research is in the form of case studies and series. There's no big research on paranoid personality disorders because they're not very common in the clinical setting. Cognitive therapy and psychodynamic psychotherapy are the kind of psychotherapies that you would use. You want to allow the person to have control and not embarrass the person directly by belittling them. And if it presents in the clinical setting, it's often due to other complicating features such as violence towards others, drug use, or other things. So someone with paranoid personality disorder may be more prone to use certain drugs or certain, or be violent if they really think somebody is doing something behind their back, or if they accuse their spouse of having infidelity in a paranoid way where there's no real evidence, but they'll lash out maybe. So those are the times where maybe medications could be useful. Any questions on paranoid personality disorder before I move on? Kind of get the gist of it? Can you tell me a little bit about paranoid personality disorder? Yes, my old Mehdi student. She used to be one of my students in the Mehdi program back in the day. I didn't mean to put you on the spot.
No, it's not very psychological. Like you said, they can lash out.
Okay. All right. And I guess, and I'm not trying to like put anyone, I just want to make sure that you guys are understanding, so I'll do that. All right, schizoid personality disorder. So this is another one of the cluster A personality disorders, right? And it's going to have a lot of, so cluster A are all going to have some similarities. They're all kind of going to be eccentric and odd. There's a pervasive pattern of detachment from social relationships and a restricted range of expression of emotions in interpersonal settings beginning by early adulthood and present in a variety of contexts as indicated by 4 or more of the following. They neither desire nor enjoy close relationships, including being part of a family. Almost always choose solitary activities. Almost always. It's not like I'm an introvert. No, they don't want to be part of a family. They don't want to have friends. Has little, if any, interest in having sexual experience with another person. Takes pleasure in few, if any, activities. Lacks close friends or confidants other than first-degree relatives. Appears indifference to the praise or criticism of others, and shows emotional coldness, detachment, or flattened affect, meaning their affect is always kind of just flat, right? So 4 or more of these things would constitute a diagnosis of schizoid personality disorder. Don't make the diagnosis yourself. It takes, interviewing someone and really getting to know them from a clinical standpoint. Now, some people ask, what's the problem with that? If someone's happy like this, why? What's the issue? There's no issue. If you're fine, if someone is fine, then they don't have a disorder, right? This is how they live. But usually these people are brought in by either families or people who are worried about them. We'll bring them in because it's starting to cause some problems and rifts within the family and within that kind of thing. But if somebody is just doing their thing and that's how they are and they're happy, then that's not, you don't force somebody to come see a doctor and get diagnosed with something. This affects about 2 to 5% of the population. They often work solitary jobs, so I think of like a nighttime janitor or a nighttime security guard. Like those are the kind of jobs that they'll take, jobs that don't require any interaction with anybody else. Jobs that maybe a desk job as an accountant somewhere, but that in the back room, right? Research shows that it may be on the same spectrum as schizophrenia, but the person is in touch with reality. But families, someone who has schizoid is likely to have family members that have some type of schizophrenia type of clinical picture. Brief psychotherapy working on basic communication and life skills can be very helpful with these people. Again, it's not schizophrenia. So schizophrenia, that's a whole other topic that we're not going to talk too much about today. So I could answer brief questions about schizophrenia at the end of this, but this is not schizophrenia, but it's on the, it could be, there's some research to show that there are some genetic and familial and patterns that are similar with schizophrenia, and people that have this disorder are likely to have family members with schizophrenia, and sometimes people with this disorder can go on to have schizophrenia. And schizophrenia, as we know, it's a psychotic disorder. It's people who hear voices, see things, completely delusional. Their affect is also flattened. They have very, they like to be also alone and all that. So, but this is more of a cognitive style rather than a psychotic disorder. Then we have schizotypal personality disorder. This is a pervasive pattern of social and interpersonal deficits marked by acute discomfort with and reduced capacity for close relationships, as well as by cognitive or perceptual distortions and eccentricities of behaviors beginning by early adulthood and present in a variety of contexts, 5 or more of the following. Ideas of reference, not delusions of reference, ideas of reference. So they might think that they have guardian angels that send them signs and symbols at different places, but it's not to the point where they think the TV's talking to them or the radio's talking to them, but more like they have some ideas of reference. They think like the world kind of revolves around them a little bit. There's some narcissism there. Odd beliefs or magical thinking that influences behavior and is inconsistent with the subcultural norms. So when you're diagnosing this, you got to make sure you understand the culture of the person. So you're not misdiagnosing somebody. Because if there's a cultural norm that somebody holds to that seems eccentric or weird to you, but if it's a cultural norm for them, then that's not a disorder. So superstitiousness that doesn't go fit with the culture that the person is from or in. Belief in clairvoyance or telepathy or sixth sense in children, and in the children and adolescents, bizarre fantasies or preoccupation with bizarre things. Unusual perceptual experiences, including body illusions. So they might have different tingling, different sensations in their body that they're attributing to angels or something like that, and it's not really, there's no physical reason for it. They have odd thinking and speech, so vague, circumstantial. They go around in circles and circles when they talk. They are they could be very metaphorical or over elaborate. They're suspicious. They could be suspicious or paranoid as well. So again, it's 5 or more of the following. Inappropriate or constricted affect. So their affect is inappropriate for the way their face is inappropriate for this. Could be inappropriate for their circumstance. Laughing when there's nothing really that funny, or very flat or constricted, like they don't smile much or frown much or get sad much. So it's kind of just a very limited range in things that they express on their face. Behavior or appearance that is odd, eccentric, or peculiar. Someone might be wearing, you know, a cape all the time because they think eventually they're gonna gain the power to be able to fly. But that's not, it's not psychotic, because in reality they know they can't fly now, but eventually if they work up to it, they could fly eventually, so they wear a cape everywhere. That's just an example. Lack of close friends or confidants other than first-degree relatives, and excessive social anxiety that does not diminish with familiarity. So even when they're familiar with something, tends to be associated with paranoid fears rather than negative judgments about self. So they're not. It's not like they're nervous to go into a public situation because they're afraid of judgment. It's more that they're just paranoid. About 3% of the population. More likely in families of schizophrenic patients, may be involved. These people may be the people that would be involved in cults or strange religious practices or occult kind of things. Now, if you're interested in the occult or in the occult, like the occult is like the spiritual dimension or demons or whatever, that doesn't mean you have schizoid or schizotypal. It has to, like I said, it's 5 or more of the following, right? There has to be a consistent behavior of that. In psychotherapy, clinicians should be non-judgmental. And you could use antipsychotics or antidepressants appropriately to alleviate some of the symptoms. So these are kind of just odd and eccentric people. And again, if they're not causing any problem, they're not going to come to, they don't need a diagnosis, right? It's when it's becoming a problem, families will bring them in, or someone will notice that this is problematic, it's an ongoing thing. Maybe someone did join a cult or something, and it's getting kind of weird for the family and for the person himself. So we could see how they will end up in the clinical practice, but we could also see why some of these people may not need to be diagnosed or may not need to be, if they're not harming anybody or themselves and they're fine. Does that make sense? So we move on to cluster B. We have narcissistic. This is one of my favorite clusters in personality disorders, just to let you know. Narcissistic personality disorder, borderline personality disorder, antisocial personality disorder, and histrionic personality disorder. So narcissistic personality disorder. This is a pervasive pattern of grandiosity. So grandiosity, someone thinks they're so grandiose, right? In fantasy or behavior. So either they're always fantasizing about how amazing they are, or they behave that way. Need for admiration and lack of empathy beginning by early adulthood and present in a variety of contexts as indicated by 5 or more of the following. Grandiose sense of self-importance. They exaggerate their achievements and talents and expect to be recognized as superior without any real substance for that superiority. Preoccupied with fantasies of unlimited success, power, brilliance, beauty, or ideal love. Believe that he or she is special and unique and can only be understood by other special and unique people. Requires excessive admiration. Has a sense of entitlement. Lacks empathy or is unwilling to recognize or identify with the feelings and needs of others. Is often envious of others or believes that others are envious of him or her. Shows arrogant behaviors. Sounds like a lot of people. No, I'm kidding. 1 to 2% of the population, more common in men. And it stems, we think, especially if you think psychodynamically, which I'm very psychodynamically oriented, meaning I think of the unconscious and the structures of the mind more than I do of just the cognition and what the person says. And if you think psychodynamically, then you think that we tend to feel that there's a failure in maternal empathy and early rejection or loss. This is a very early insult happens to the person's ego when they're very young, at a very young developmental stage. And if it happens at a young age, it probably happens throughout their formative years of childhood. So it's a cycle of this type of thing that happens early on that leads to this defense mechanism of needing to be superior, to defend oneself against the inferiority that has been pushed on them from an early age. Group therapy and psychodynamic, psychoanalytic therapy may be effective. Narcissistic personality disorder people tend to be, from my experience, intelligent, smart, and do well in insight or open-ended psychotherapy. And we think someone who's constantly lashing out at others. You disagree with them and they lash out at you, or they make you feel inferior all the time, or they're always, very pompous, right? There's a big we have an ego, right? Let's say this is our ego or who we are. And they have this huge, their ego is kind of like this, but it's the same ego, right? But it's so expanded, so it's easily popped. So anything can really, it's too bloated, right? It's like a balloon that pops really easily. So it's always getting injured. So we call those narcissistic injuries, where everything injures this person. They lash out, and they come after you, and they're vindictive, and they're angry, and it's really, all of this is just a defense against an inferiority complex. So it's a superiority complex that's really a defense for an inferiority complex. Two sides of the same coin, right? It's always, you'll notice with a lot of disorders, there's an apparent and then another side to that thing that's equally, but more hidden, right? The inferiority is more hidden. That's what you want to bring out in the psychotherapy when dealing with this. You could see how this could be very toxic on a marriage or on a family or with friends. They're toxic, and they're toxic because of what's going on internally. So me as a psychiatrist, I don't judge, but other people will judge, and they'll push these people away, right? So without help, without recognizing that they need help, they're constantly pushed away. So while they're toxic, they're seeing everyone else as toxic, right? So they're seeing everyone else as attacking them as well. So it's a two-way street in their mind. And at the end of the day, they're really victims of their circumstance. So that's where the therapist and psychiatry comes out in me, where I really try not to judge or push anyone away, because I know that what you're feeling from somebody, so when they're being toxic, what you're feeling from that person is generally a mirror reflection of what they're feeling about themselves. They're projecting that onto you in a way. So whenever you get, so I always remind myself when I'm dealing with a very difficult patient who has a personality disorder, that what they're pushing on me, if I'm feeling this annoyed with them, right? That's how they're feeling about themselves all the time, right? This is just a defense. They're just trying to push that off onto you. So that's kind of one way to think about it, so that you don't get very upset when confronting someone like this, or even confronting yourself and understanding, maybe I have some of this, and maybe I hope that this, this will give you some insight. And the famous borderline personality disorder. It's a pervasive pattern of instability of interpersonal relationships. Sorry, back to narcissism. Just came to mind. Who's a good example of narcissistic personality disorder from the Quran? Yeah, Fir'aun, right? He got so narcissistic to the point where he believed he was God, the God complex, right? It's very interesting. Borderline personality disorder. This is a pervasive pattern of instability of interpersonal relationships, self-image, and affects, and marked impulsivity, beginning by the early adulthood and present in a variety of contexts, as indicated by 5 or more of the following. Frantic efforts to avoid real or imagined abandonment. A pattern of unstable and intense interpersonal relationships characterized by altering between extremes of ideation and devaluation. This is a very nice personality disorder. So I'll explain these. Identity disturbances marked by persistently unstable self-image or sense of self. Impulsivity in at least 2 areas that are potentially self-damaging. Spending, sex, substance abuse, reckless driving, binge eating, etc. Recurrent suicidal behavior, gestures or threats, or self-mutilating behavior. Affective or emotional instability due to a marked reactivity of mood, so their mood is extremely reactive. Chronic feelings of emptiness, inappropriate intense anger, or difficulty controlling one's anger, and transient stress-related paranoid ideation or severe dissociative symptoms. 2 to 5% of the population has this. These are all rough. Most will also have another psychiatric diagnosis. You rarely find someone who has borderline personality disorder that doesn't also have a diagnosis of depression or anxiety or fibromyalgia or migraines or a series of other things, right? Interestingly, they're very sensitive to pain when it's not in their control, but they can self-mutilate, and that relieves their stress. So they're very sensitive to pain, like migraine or fibro. They have like this heightened nervous system. Everything is heightened. It's like people walking with antennas that are like 10 feet wide, and they're just feeling everything, right? And but at the same time, they can self-mutilate, and it doesn't hurt them as much as you would think it would. Common amongst relatives with borderline personality disorder. One psychiatrist once told me borderlines beget borderlines, and it's partially due to the social situation and also some of the biology. A head injury or perinatal injury accounts for some of the presentation. So sometimes they'll have some head injury early on, or some injury when they were in the womb or something like that. That can account for some. Always, as a rule of thumb, I think it's about 40 to 60%. Please don't quote me, but double check or fact check me or whatever. It's I think 40 to 60% have a history of physical and sexual abuse, abandonment, or other involvement that often present in the person's history. They have this defense mechanism called splitting. They also have projective identification as a huge defense mechanism, and they have the fear of being abandoned. And the DBT, or dialectical behavioral therapy, is a treatment of choice. So what's splitting? So splitting is, I like you, Kareem, and I can't just like Kareem. I love Kareem. Kareem is the best thing that's ever happened. I start to dress like Kareem. I start following Kareem home. I'm Kareem, right? And Kareem is my best friend, and I talk to everybody about Kareem. Kareem does something that I don't like, or I notice something, or Kareem doesn't meet my expectations one day, or I notice something that Kareem has doesn't really fall into what I had in mind of Kareem, because I had such an idealized version of Kareem that he can't attain. Kareem is the worst human being ever. He's disgusting. He's despicable. He's evil. He's awful, right? And then Kareem does something else that's good, and I'm like, this guy's the best guy ever, right? Not today, not like this is such a nice thing. He's the best guy ever in the whole world. I've never seen someone better than. Then I'll hate him again. That's splitting. Another way that splitting can happen is Kareem is all good, Ali is all bad. So I start splitting between them. Kareem, you're better than him, right? So patients will often come to me, and so with borderline personality, the nurse is really bad. She's not good. She's a terrible nurse. And they'll go to someone else. That nurse is horrible. So they'll start splitting staff. So what I call is called staff splitting. So when we have a real serious borderline on the unit, we meet with all the staff, and I talk to them, and I say, all of us have the same message. Let's not let the splitting happen, because it will tear up the thing. Now, when I was a resident and I had a attending over me, right? The patient was like, "I like you. You're so much better than the attending." And me, I'm so good. Like, yeah. And then the attending just comes, one time comes up to me, he's like, "Dr. Shibak, you know that's just splitting. She's just stroking your ego." And just like, that is splitting. You're so right. So like, you fall into it, to an untrained eye, you'll fall right into this, right? It's very manipulative. These are very stably unstable people. They're stably unstable. They're always unstable. And this is, it's such a difficult disorder because there's so much suffering going on in the patient. And that suffering, they'll throw it at you. They really do project it onto you, and you start to suffer with them because you, and if they're bad enough or manipulative enough, I don't like to use that word, but if they're manipulative enough, then you really start to dislike them or push away from them because they dislike themselves so much. They've suffered so much, they've been abused, right? So what does splitting happen? So this person some of them are abused by family members. So that family member that abused them, that uncle or the mom or the dad, right, that's abusing them and neglecting them, what's going on? That's the same person that's giving them nourishment and food and this. So that person has to be, so to defend themselves, they box this person into all good and all bad, right? That's the only way they can deal with this person that they love and also hate this person, is to all good and all bad. So they learn this at a very young age. Our kid does that, Musa, because he's at the age where he, sorry, but he's at the age where splitting is common in toddlers, right? This is a very early insult. So at that age, it's very common. So when he's happy with me, he wants me to put on his shoes. When he's happy with his mom, he wants her to put on his shoes, and he won't let me put on his shoes if he wants her to put on his shoes. And I'm using him as an example, sorry. So for us, for a little kid, you are all good or all bad. But if you insult and injure them so much at that age, or small insults over a period of time, little tiny insults here, it becomes traumatic for the kid. They develop this different frame of reference, this different way of thinking. And that's where this arises from. It arises from infancy, from young, especially from a psychodynamic perspective. We definitely think that it starts at a very, very young age. During infancy, it starts, really. You know, kid is hungry, they want milk, they don't get the milk, all bad, all good. So it really starts at a very young age. Projective identification is if I think of someone in a certain way, I think of myself a certain way and someone else in a certain way, and I start treating that person the way I believe them to be, that person starts to act that way towards you. So it's a very powerful defense mechanism, very primitive and a very manipulative defense mechanism, but that's what projective identification is, when they force someone else to act in the way that they want them to act by acting towards them that way. So they think I'm a bad doctor, they'll act at me, they'll be a terrible patient to make me a bad doctor, so they, there you go. Or if they think you're saintly or a mother figure, they'll act towards you as if you're a mother figure, and you start acting in that way. It's similar to projection, but it's a little bit more complicated. It's hard to really explain it unless you actually feel it and get really confused as to what's going on, and that's kind of what projective identification is. When you're in a situation like, what's going on here? That's probably projective identification. Their ego structure is very weak. So that's why they're easily, someone with borderline personality will adapt to someone else's behavior because they don't have this chronic sense of emptiness that I talked about here. It's an emptiness in the ego. The ego's missing a piece. And they're filling it in with these other people. And so they never really have a structure for themselves. What dialectical behavioral therapy does is it really tries to get the person to be aware of their emotions and aware of their behavior. And it takes a lot of patience. I could never do DBT. I can never work with this, only with this substance. I love this personality disorder. I think it's fascinating psychologically, but the people who do DBT and the patients that actually go through DBT are fascinating people. The person who developed DBT is Marsha Lanahan, and she's actually someone who had borderline personality disorder. She developed the therapy for it. And it's basically the therapist has to be very patient. There's a lot of communication between therapist and the patient, and a lot of work is done. But it's very helpful. And there's some group DBT as well, which is good because it gets borderlines to have some type of support network as well. In adolescence, I do a lot of, right now I just work with adolescents. A lot of adolescents will have features of borderline personality disorder because their brain is not fully developed yet. So like I said, borderline personality disorder is an insult somewhere throughout their development. So their brain kind of has a different way of working. They're kind of like walking limbic systems. The limbic system, the thing that has all the urges and all the anger and all that, is not really being controlled a lot by the frontal part of the brain, or the prefrontal cortex. And adolescents don't have that connection completely. That connection is really not completely done until you're like late 20s, early 30s, where there's a balance between the brain. So a lot of people who are younger will have these tendencies. That's why I don't diagnose it in adolescence. But I'll see the tendencies. I'll know that someone is going to be, or they're going towards that path because they're very extreme. But a lot of adolescents will have more features than others, and young adults will have more of these features because tend to be more impulsive and things. The brain is not completely developed yet. But you can diagnose it in adolescents and young adults, especially if it's very severe. You know, sometimes you have adolescents that are cut up from top to bottom, mutilating themselves, right? Or completely staff splitting, not what's normal for an adolescent. But you do have to keep in mind what's normal for an adolescent and what's not normal for an adolescent before you make such a diagnosis. Make sense? Yeah? You guys ever watched that movie, Obsessed, where some lady falls in love with somebody else and then she starts stalking him and his, no? Nobody's watched it? Yeah. Yeah? Okay. So that's the lady that's stalking him. That's an extreme form of borderline personality disorder. Stalkers tend to have, the stalkers are extreme borderline structure. Antisocial personality disorder is a pervasive pattern of disregard for and violation of the rights of others, occurring since the age of 15 years old, but can't be diagnosed until 18 or young adulthood, as indicated by 3 or more of the following. Failure to conform to social norms. That's where the antisocial comes from. It's not that these people aren't social. Antisocial means they're antisocial norms, antisocial law and order, right? Anti-society, right? So failure to conform to social norms with respect to lawful behavior, as indicated by repeatedly performing acts that are grounds for arrest. Deceitfulness, as indicated by repeating lying. Use of aliases, I don't know how to say that word. Aliases. Or conning others for personal profit or pleasure, impulsivity or failure to plan ahead, very poor planners. Again, it's 3 or more of the following, so some of them will have different aspects of this. Some of them are excellent planners and plan way far ahead, and some of them are terrible planners. Irritability and aggressiveness is indicated by reported physical fights or assaults, reckless disregard for safety of self or others, consistently irresponsible, as indicated by repeated failure to sustain consistent work behavior or honor financial obligations. Always bored. They're always bored, right? They don't have an inner life. They're very bored. Lack of remorse is indicated by being indifferent or rationalizing hurting, having hurt, mistreated, or stolen from another. Oftentimes in adolescence, will start by hurting animals or stealing from stores or shoplifting. Then becomes conduct disorder. You know, this person's always in trouble with juvie or something like that, and then eventually becomes full-blown antisocial personality disorder. 1 to 3% of the population can be as high as 70% of the prison population. ADHD and conduct disorder are predisposing conditions. Why is ADHD a predisposing condition? Well, if ADHD is not treated, ADHD, one of the symptoms of ADHD is extreme impulsivity, and you're always going to be impulsive, always going to break the law, and eventually, not everybody with ADHD, but I'm saying if you have that ADHD, you're more likely to be impulsive. And if that impulsivity gets out of hand, then you're going to break the law and you're going to do things that aren't good. So that's why it's very important to treat ADHD. One of the reasons it's important. There's many reasons why you should treat ADHD if it's real. And conduct disorder are predisposing conditions. So conduct disorder is basically antisocial personality disorder light, the light version or the diet version when you're younger. Some genetic factors are involved. Brain damage or dysfunction is a feature. Poor planning ability and judgment. Psychotherapy can actually almost be impossible with this subset of population because they can be very manipulative. Some of them can be very charming. Not all of them. Some of them are not charming at all. Some of them can be very charming, very charismatic, and very good planners and very good manipulators. Others are terrible planners, not charming, and just kind of criminals. But either way, it's very hard to do psychotherapy with someone who really has no remorse for you or no regard for you. Sees you as an object. Pharmacotherapy is used to control impulsive violence, and psychotherapy can be used, but only a very trained psychotherapist really should be working with antisocial people. If you're doing psychotherapy and by the end of the session you've given your patient $40, then you probably just had someone with antisocial that you were just doing psychotherapy and they just conned you out of $40, right? So it's you really have to be trained to work with them in psychotherapy. But pharmacotherapy, meaning medications for controlling impulse and anger and things like that, can be used. Some people will say antisocial personality disorder are the psychopaths, right? Those serial killers. Well, that's maybe. Serial killers or psychopaths that aren't serial killers, but just psychopaths, are definitely cluster B, but they're kind of a mix of all of these, right? So let's not say psychopaths tend to be charming, charismatic, good with words, shallow, don't have remorse, but they can really imitate emotion very well. And they are the ones that go on to either do a lot of killing or a lot of big con jobs or things like that, and they just have no remorse. That's not necessarily, there's antisocial aspects to it, yes, but there's also narcissistic aspects, sense of self-love. They love themselves so much. There's also some borderline, they're splitting, the person they're about to kill, some of them may be able to kind of turn on and off that emotional switch that most of us don't have that liberty of doing. So it's not necessarily that all psychopaths are antisocial. They're antisocial, but they're also a mix of other things. And that's a very fascinating topic in and of itself, because every person who commits these planned and meticulous crimes, whether it's finance or serial killers or things like that, is a little different. So it's not like they're antisocial, it's the same thing. So that's where you go more into depth. When you talk to one person, you go more in depth in their history and try to really weed out who they are and what they are, right? So this is more like, like I said, the diagnosis, this is for diagnosis purposes, but really, every person is going to be different. That's where the investigation comes in. That's where you use that clinical interview and that ability to really be a detective and figure out what a person is. There's some speculation that Adolf Hitler was actually, some say he was antisocial, but there's more speculation that he was actually borderline, and that he was able to split. The German race is all good, the Jewish race is all bad, the Gypsies are all bad, there's no in between, right? That's a borderline type of cognitive thinking. There's also, but he actually also had antisocial aspects as well, right? So do many other people, right? All right. Histrionic personality disorder. Sorry, any questions about this?
What is the best solution for the ADHD?
ADHD?
Medications.
Medications. ADHD is medications, yeah. If it's real ADHD, it needs medications. Psychotherapy and all that for ADHD specifically doesn't really work. Because ADHD, there's a problem with the brain itself. It's not, if it's real ADHD, there's not real ADHD. And it takes a real diagnosis. We do neuropsych testing, we do interviews, we do a lot of things to diagnose somebody with ADHD. Yeah.
I have a question.
Yeah.
Can somebody have multiple disorders?
Oh, absolutely. And multiple. Yeah. Yes. Actually, we saw in the cluster A, right? Paranoid personality disorder has some similarities to narcissistic personality disorders. So yes, someone can have two personality disorders. I've done that. I've diagnosed that once or twice. But usually, if someone does have many personality disorders, then it's probably what? Borderline, right? They're just kind of going through. But yeah, you could definitely have more than one personality disorder. Yeah. Yeah. Did you turn down the mic? No. Oh, okay. Sorry. Histrionic personality disorder, pervasive pattern of excessive emotionality and attention-seeking beginning by early adulthood and present in a variety of contexts as indicated by 5 or more of the following. Uncomfortable in situations in which they are not the center of attention. Interaction with others often characterized by inappropriate sexual, seductive, or provocative behavior. Display rapidly shifting and shallow expressions of emotions. Consistently use physical appearance to draw attention to self. Has a style of speech that is excessively impressionistic and lacking in detail. Shows self-dramatization they're theatrical. and exaggerated expressions of emotions. Susceptible to, very suggestible, easily influenced by others, and consider relationships to be more intimate than they actually are. So the type of person that you tell them your dog died and they're more sad for you than you are for yourself, but they're not really sad. Oh my God, your dog died! Oh, right? And they don't know your dog. They don't care. Right? Really, it's kind of like the twin to borderline personality disorder, but it's less dark, I guess. But it could be just as problematic. But I think of it as it's kind of a little bit more shallow than some of the other cluster Bs. Very similar to narcissism as well, with the sense of wanting to be center of attention. But there's less about the I'm entitled, more of I just want to be the show. I want to be the center of attention. Seductive is one main feature, often very seductive and very, they suggest a lot of things, and they really try to use that to their advantage. They think the relationships are a lot deeper than they actually are, right? While borderline personality disorders have intense relationships, but they're very brief and unstable, at least as a hallmark, but not everybody. But borderlines have like this rapidly changing relationships because they're splitting so much, while these have like these relationships that are kind of shallow, but they think they're so deep, right? 2 to 3% of the population may be associated with somatic symptom disorder, so they could somaticize a lot. So histrionic, if you remember my first talk I gave, I talked about hysteria, right? The birth of psychiatry with Freud and Charcot, if anyone was here. Anyone remember that? Long time ago. But the birth of psychiatry came from hysteria, these women that were having these fake seizures back in the 1800s, and Freud and another Dr. Charcot were working with them, and Freud kind of developed psychoanalysis from that. Hysteria, same kind of root word, hist, that first part of that word, like the hysterectomy, right? You're thinking womb, you're thinking of females, right? And that's not necessarily, a lot of times this disorder is not, it could be diagnosed in men, but it's not, it's more diagnosed in women. But it comes from that same thing where they're hysteric all the time, right? They have the hysterics, they have pain that comes because they're so stressed, they have fainting spells, they have these types of things. Those come along with histrionic personality disorder because of the shallow but attempting to have deep level of emotions, right? They learned early on to resolve interpersonal difficulties by dramatic behavior, so that's where it kind of stems from. One distant parent and one overly seductive parent may be a pattern in some instances. Often repress and regress, and they somaticize. So somaticize means they turn psychological trauma or psychological stressors or emotional stressors that they're having into physical pain or physical issues. Overt seductiveness, but may actually be uncomfortable with sexuality when you dig deeper into them with the interview. Insight-oriented psychotherapy is good, and antidepressants are appropriate if they also have concurrent depression, because they're likely to suffer from emotional and mood disorders as well. Cluster C is brief. I'm not going to go too much into depth. It's interesting, but I've never really gravitated towards the cluster C personality disorders, but they're interesting nonetheless. But I kind of summarized them. Avoidant personality disorder, they're shy. So cluster C, we said they're the anxious and fearful. Avoidant personality disorder are shy and timid, intense sensitivity to rejection. They're not asocial, they want to have social interaction, but they need reassurance and a guarantee that there's going to be uncritical acceptance. So they want social interaction, but they're afraid because they feel like they're going to be rejected. So if you guarantee that they're going to be accepted 100%, then they're fine. It's impossible to do. So it's very hard for them to kind of navigate that. 1% of the population may be due to a deformity. They could have the physical deformities that have kind of, from a young age, that kind of led them to be this way, feel rejected. Parental deprecation, so parents that are constantly hard on them and don't really, they're very, deprecate them. Overprotection, so two sides of the same coin, right? Deprecation, hard on them, not very emotionally supportive. Fish haniyya. So deprecation or overprotection, right? Two sides of the same coin again. You're seeing the same thing. You're seeing that deprecation and overprotection are really two sides of the same coin and lead to very similar outcomes. Overprotection, phobias in the parents themselves. So the parents have phobias of everything. So when the kid learns, they don't have a phobia, they learn to always be cautious and not take risks and things like that. Group therapy is very helpful, as well as assertive training. So training someone to be more assertive in their demeanor. But group therapy is good because it forces them to be in a situation with other people, and it sort of gets them to open up a bit and not be so timid. Obsessive compulsive personality disorder is different than OCD. It's different than obsessive compulsive disorder. This is a personality disorder. This is more about rigidity and perfection, while OCD, the other OCD, which is the ornament, right, that goes on the Christmas tree, that's more of, so OCD is more like, okay, I need to put this remote right here, and it has to be exactly here, and I have to count 8 lights, right, and then I have to touch this 8 times, and then go like this. That's OCD, right? Those are like, it's rituals. Obsessive compulsive personality disorder. I have to touch this with this hand. Sorry, I have OCD. Oh. Remember? So obsessive compulsive personality disorder is different in that it's about perfection. It's about rigidity. It's about following the rules, right? It's different than OCD, and it's about stubbornness. The person's very stubborn. Emotional constriction, indecisiveness. Everything's about rules and regulation. You'll play a game with them, and the game becomes more about the rules of the game than the game itself, so it's like, it's not fun. Very moralistic, judgy, right? They have moral high ground in everything. They're very judgy, very moralistic. They have a code. And in therapy, they try to come off as very intellectual, and they intellectualize everything, and everything has, you know, just very kind of, I don't like to say these, but it comes off very boring sometimes in psychotherapy when you have someone with this, because it's their way, and it's just kind of dry, and just goes on and on and on. Just and really the problem is that their families are, you know, they've had enough of it. Very frugal, right? They don't spend any money, saving all the time, and just everything has to be done the same way all the time. So it gets really annoying for families. And they sometimes, now a lot of people with obsessive compulsive personality disorder are okay with it. It's going along with what they want. That's their ego. It's fine. It's meshing well. But sometimes when it gets really bad, they can't handle it anymore. It's too much. Everything is a big ritual, right? Everything's a big planned out thing. So they seek help, and psychotherapy, obviously individual psychotherapy, is very good for them. Dependent personality disorder, they're often dependent and submissive, lack self-confidence, rely on others to assume responsibility over their lives, 2 to 3% of the population. A lot of times you'll see either they had a parent who died when they were in childhood, they have a physical illness, or separation anxiety may often be found in these patients' histories. And insight-oriented psychotherapy is the best, or one of the better methods to use with them. And I think that's it. So we'll go back to the tale of Narcissus. So what did we see when I told you in the beginning? I started with the Greek myth of Narcissus and Echo. This is just fun part of the discussion. So he looked in the pond, right, and he almost fell over, ended up killing himself, fell too in love with himself, he turned away everybody else, right? It's a pattern with a lot of these personality disorders. But I look at the phone, right, and the camera is kind of the pond that we use nowadays, right? We take these pictures and take like 17 shots, and we don't like how our nose looks or something, right? We kind of almost fall into the phone, right? At the expense of our relationships with others, right? So this is not, this is just me going off on a tangent. I do that, so. But I think that we're doing a lot of what Narcissus does. He looked as a society, and I think we have to sort of start to change a little bit. When he looked in the pond, and that was so mesmerized with himself that he just kind of disappeared into it, right? And I think sometimes with us, we're looking at Facebook all the time, and we're doing this, and we're always, and it's okay. That's okay. I go on there. It's fine. But I think we're doing it so much that we're neglecting other people. We're becoming like Narcissists. We're becoming so engulfed with ourselves and our echo, right? We're creating echo chambers. Narcissus had that echo, right? That she disappeared, but we're also creating echo chambers. We only talk to people who think our way, or we only associate with others who are exactly like us, so they could remind us of how amazing we are. So as a society, we have a narcissistic society. It doesn't mean we all have narcissistic personality disorder, but I'm saying as a society, it's kind of moving in that direction where society is becoming that way. We validate only ourselves, right? We only have friends that will validate us. We only take pictures that look amazing, right? I have pictures and photo albums, right? Old pictures that are like, they're terrible. That's how it used to be that way, right? So Doesn't mean we don't progress and everything has to be the way it used to be, but I'm just saying these are things to think about. Sometimes there's so much wisdom to be gained from mythology and parables and stories, and I think we need to kind of go back to reading some of these things and taking some wisdom from it. With that said, we are done. I could take questions.
Okay, a question here.
Yes?
Is there any study that shows the effect of the spirituality over these people?
There's
One group,
So there's a lot of studies that show the effect of religion, that it helps alleviate or helps cope with or deal with mental illness in general. I don't know of any that deal with personality. I'm sure there probably is. I don't want to answer wrong and just tell you that, yeah. But I know that there are studies that talk about religion being a protective factor, something that protects against suicide, for example. Religions that say that suicide is forbidden tend to protect against suicide. That doesn't mean someone who's a Muslim will never commit suicide. No, absolutely. People will commit suicide from all religions, but it tends to protect. It makes it less likely, right? So religions that do that, so I think Islam, Catholics are very strong against suicide, so they tend to have less suicides. Practicing Jews, and I don't know if Hindus or Buddhists have any laws, but I think those religions the ones that have actual laws against suicide tend to fare better. But they don't protect against necessarily having suicidal thoughts. They don't necessarily make depression less likely, and they just make it that you can cope better with the depression that you have. So, ta'tamid ala Allah or something like that, and that helps people. Spirituality without religion can also help with mental illness, but it's different. It doesn't really protect against the same things. But religion can help. But let me warn you guys, I think that it can help, but it doesn't mean that the way it's helping. So let's say I'm not committing suicide just because I feel really guilty. Does that really help? I mean, yeah, it's help. We don't want to commit suicide. So yes, suicide's haram. Yeah, sure. But if I have the thoughts anyways, is that really, and I just feel guilty, that's kind of almost like a second, sometimes religion can add a second dimension of anxiety and stress. So now I feel guilty that I have suicidal thoughts. Now I feel, especially if you have OCD, obsessive compulsion, you have these sticky thoughts, and now you think that every time you think of suicide that God hates you or this or that, and so religion can create a lot of tension as well and a lot of anxiety. So religion needs to be practiced mindfully, and I think it's the jobs of ulama like you to really teach people that way, because otherwise people are going to take, people that are susceptible to mental illness will take religion in the wrong way, and it'll cause a lot more stress and anxiety. So yes, religion is protective. Islam is a very protective religion. A lot of wisdom, just like there's Greek mythology, we have stories and parables in the Quran that teach us a lot of these lessons. So these things are very protective, very good to go back and read and to feel union with Allah, but sometimes it's just a lot of guilt is involved in it. We don't always feel spiritual. I don't always feel spiritual. And I think that's okay. That's part of mental. It's okay not to always feel spiritual, especially in this world. We're always so busy. So it's good to have a balance, and to, when you do feel spiritual, to practice it mindfully and not in a judgy way where you're too hard on yourself, right? We're always telling, muraqaba, muaqaba, mashara. It's good, huh? ايه جهنم ومراقبة ولازم تراقب حالك ومعاقبة yeah, sure, but we have to also be mindful that people's mental illness is at stake here, and also start teaching, I think, religion in a way where it really opens our hearts rather than just makes us terrified.
And the approach will be different from person to another.
Absolutely, yeah, I think so. Yeah, that's my opinion. I mean, that has nothing to do with psychiatry. You guys can disagree or agree, but that's my opinion. I think that religion needs to be taken a little differently. Even when it's not fear, right? I mean, it's not like every time I go to mosque they're terrifying me, but the society sometimes terrifies one another, and we keep ourselves in these little boxes, and you're so afraid to express anything outside of the norm. And this is religion, politics, social things, everything, right? I'm a Democrat, therefore this is my beliefs, and you're bad. And I'm a Republican. Who cares? What are you guys doing, right? Or religion. I'm Shia. Okay, good. Alhamdulillah, good for you. Like, that's good. But let's move it to the next level, right? Yeah.
For the personality disorder, if someone suffering through a personality disorder, is there any way
Yeah, I think I spoke about that with almost all of them, except antisocial is the only one that's really difficult. They're all difficult, but antisocial is the one that's really probably the most difficult to change. Yeah, because you change their if you do cognitive therapy, right? You're changing their cognitive perception, the way they think, right? So personality, a lot of them are about a wrong way of thinking, especially the cluster A personality disorders. There's a wrong way of thinking. They're thinking in a wrong way. So if you could change that cognitive, if you could reframe the cognition. With cluster B, if you do like some psychodynamic psychotherapy and get really deep into the childhood and resolve untangle some of those knots that exist from childhood, it takes time. And as a psychiatrist, I love this stuff. I love psychodynamics. Like I like psychoanalysis. I like this stuff, but I don't have time. So we need more, I think, therapists who really dedicate their life to therapy. Right. So as a psychiatrist, you know, we're so busy because there's so many people that really need medications and things like that, and they really do. So that I don't really have the time to do the psychotherapy. I wish I did, but I don't have the time. So we need more people that are that really stick to psychotherapy and do these things. And but yeah, you can change them through therapy. And eventually, some of these personality disorders, like borderline personality disorder, it starts to kind of fizzle away around 50, 60. It's kind of, they burnt out all their energy, right? So they're good by that day. No. Each person is different, but yeah. I think you could do time-limited psychodynamic therapy. Psychoanalysis, that's expensive and nobody has the money to pay for that, and that like lasts 3-4 years. So, I mean, I'm not saying everyone needs to go into psychoanalysis because it's expensive, insurance doesn't pay for it, and you gotta go 3-4 times a week. But psychodynamic is derived from that. It's a derivative of psychoanalytic, and you could do that for time-limited, 6 months or something like that, and once a week or once every 2 weeks. Make sense? Yeah. Any other questions? Yes.
When you were talking about OCD, so you're mentioning examples of like how you can recognize people that do have OCD, and you mentioned like people that have like a moral code.
OCPD, the personality disorder, right?
Yeah.
Not the OCD.
Right.
Okay.
Well, is that necessarily like, when does it get like too much, or like when does it become like a bad thing?
No, yeah, morals, we all have morals. We have to have morals. Yeah, no, that's not what I meant. I meant moralistic is different than having morals. Moralistic is I'm good because I don't do something and they're bad, right? I'm better than them because they something, right? They don't do something that doesn't agree with me. They cheated in the game, always like finding the faults in everybody else but not kind of looking at yourself. That's moralistic, right? So that's different than being moral or having a moral principle. Or yeah.
Like when they practice religion itself, so like people recognize him as being like, hey, maybe he's being too obsessive, or maybe he's doing too much, or
what's culturally, we go back, in Islam, like I did some of these, we go back to urf. What's the urf? What's the, urf is the customs of the society. What's kind of the extremes of that, and what's outside of that? And this is Islamically speaking. What's outside of that is kind of, is someone that just kind of stays and doesn't sleep at night. That's a little excessive always, if they're always doing that. That might be actually mania or bipolar disorder or something else, right? Yeah. Someone speaking to Imam al-Mahdi all the time. So it becomes that those are more problematic. Yeah, but I'm not sure. I guess I'm not sure I understand the question.
I'm just like, when do I recognize that when it becomes too much, or it's starting to become a problem? Because essentially there's a lot.
Absolutely, yeah.
It'll keep you busy all day.
Yeah. I think once it does that, then it's probably too much. All right. You need to have time for your family. You need to have time for work. You need to have time to be a productive citizen for school, right? So I think once it taps into all that, that's probably a lot, right? And if you're not getting sleep at night, then you probably need to go see somebody ASAP. It's for real, and it's not a joke. If you're staying up 3-4 nights in a row, there's a problem, right? That's a problem. We all have spiritual moments, like where we do those. That's fine. We're supposed to do Salatul Layl if we have time for it, if we can. But I think when it's excessive and you're really not sleeping and you're turning away people and you're not engaged in a social interaction, that's a problem. Yeah? Any other questions? All right. Yeah. Yasmin, you could answer your own question. You're a social worker. No. But Mabruk, by the way. Yeah, go ahead.
So are these mostly related to like childhood experiences?
It's a mix. Everything's going to be a biopsychosocial spiritual mix, right? It's all these things. But somebody who has, you don't develop a personality disorder just from genetics. Unless it's I think schizoid and schizotypal, those really have strong genetic components, and those are related to schizophrenia. But other with personality disorder, you don't really develop borderline personality disorder if you didn't deal with some struggle or some problem in your life, right? So it's very social, very much social and psychological. A lot of these are all psychological defense mechanisms. So highly psychological, highly social. There's changes that happens in their brain. Like I told you, a borderline is a walking limbic system. They're just they have no way to filter their emotions. There's a structural problem. But that structural problem probably occurred because of so many social things that occurred to them, right? So I hope that answers, yeah. So it really takes more than just a gene or two to create a personality disorder. This is not like depression or anxiety or schizophrenia where there's genes or it's very biological, or like, yeah, psychotherapy helps, but you could be born with that, right? Some people who are depressed have never been hurt in their life, right? And they feel so guilty about being depressed because they have such a good life. That's different. These are different. Usually there's a lot of things that occurred to them that created the structure to be that way. Make sense? Yeah, okay. Yes?
In cases where you said medication is the way to treat personality disorder, do you ever have patients, is that like the ultimate treatment, or do you ever have patients develop resistance?
I don't think I ever said that. I didn't say medications are the way to treat personality disorders.
So like in some cases, like
I said we use medications to treat, ADHD. Oh, okay, those are different, yeah.
the personality disorder, it's also like some of their
Yeah.
do you ever develop resistance to the medication and then go back to exhibiting those initial behaviors?
Yeah, I think, so with personality disorders, so she's asking if we use medications to treat personality disorders, how do we use it to treat basically the symptoms of the personality disorders? With medications, when we're dealing with personality disorders, we're using medications to treat specific things. So there's anger, we're treating anger, we're not treating borderline personality disorder. We're treating the anger component. Or if there's impulsivity, we're treating the impulsivity with the medication. But the ultimate goal is to hopefully and be able to find some type of therapy or some type of person to work with the person. Do they develop resistance? I don't think so. I mean, you don't really develop resistance to certain medications, other medications, like if you're using benzodiazepines like Klonopin or Xanax and things, I don't use them, but if you do use those, yeah, the person's going to develop resistance because those are addictive substances. But if you're using Zoloft to help someone's mood, or you're using antipsychotics, you don't really develop resistance, at least not early on, probably very much later on, and you have to go up on the dose a little bit. But those are not the addictive substances like I said, Klonopin or Xanax or things like that to treat anxiety. So those, you could develop resistance to those. The ultimate goal is to find somebody to work with that person and to really help them with the personality disorder. And they may have to be on the meds if they have a second disorder, right? If they have a depression or something, they'll need the meds if they choose to take it, and therapy doesn't help that as well. No, go ahead.
Spiritual therapy, so foreign therapy to help with any of the personality disorders.
Sorry?
Spiritual therapy?
What about it? It's a spiritual therapy.
Right. Do you believe any like spiritual therapy could help?
Sure, of course, yeah, absolutely. If the person believes in something, finding somebody to help them with that. So I work at a Pine Rest Christian Mental Health. It's Christian based. A lot of it is Christian, but we have chaplains that come and talk to the patients that want to talk to them. Chaplains, I think sheikhs and imams have a role to play, but it shouldn't be arbitrary. And it can't just be someone makes up something and calls it a therapy. They really should be working and working with, or somehow talking with someone who knows psychiatry or knows therapy, so that they're not doing something that's actually harmful. But yeah, absolutely, I think spirituality has a big role to play for those who adhere to spirituality and to religion. I definitely a big advocate of it. Biopsychosocial spiritual is very, very important. Yes?
So this isn't necessarily related to...
Sorry, one thing. But did I answer it? Yeah, okay, go ahead.
So this isn't related to the personality disorders, but just out of curiosity, how do you distinguish spirituality from religion?
So spirituality is, I'm very spiritual and I dabble into everything, but I don't really have a solid religious tradition or book or something that I follow. So a lot of, probably more common in non-Muslim populations where someone considers themselves spiritual or deist. They believe in a God, but not necessarily a God that really controls life or anything like that. or they believe in like, you know, being in touch with nature, but there's no code or any, they develop kind of their own morals and things like that. That's more like spirituality. While religion is something that comes from it's external, and you internalize that thing, right? Yeah.
Just to add to the young lady's question when she asked about medications and personality disorders, most physicians, like including you, actually go towards cognitive behavioral therapy as first line, and then supplementing that with the medications that he was listing to treat those symptoms of personality disorders. I just wanted to make that clear.
Yeah, absolutely.
That's the first line.
Therapy, yeah. Not necessarily cognitive, but yeah, depends on the personality and the person, yeah. And the clinician. I don't do much cognitive stuff, but yeah, it depends, like cluster A's and some of these ones with severe cognitive things, definitely cognitive behavioral therapy. But definitely therapy, it's therapy and medications, right? And medications are used to treat specific aspects of it, right? I wouldn't say that that's the way other disorders, like other disorders we could start off with, we start off with medications. And therapy together, because that has the best evidence. Yeah. All right. Any other questions? All right. Thank you, guys. Thank you. Salam alaikum. Yeah. Thank you. Thank you.
I'd like to thank you, Brother Shadi, for your session.
Thank you.
Now we're finishing up with the wrap-up.